Executive Director of the network of behavioral health providers. And we're just so happy that you can be with us today. Many of you know, obviously, during the last 20 months or so of the pandemic, that we unfortunately have seen increases in the number of completed suicides across the nation. Last month, NBHP hosted a training on suicide prevention and how we could recognize some of those signs, particularly as behavioral health professionals, in order to be able to assist our clients and get them the help they need. This month, we are so pleased to have Dr. Donna Sheperis join us, and she's going to talk about suicide postvention. So unfortunately, some of the things that we need to do when in the wake of completed suicides. And we do know that that is something that a number of our behavioral health providers have been dealing with over the past several months. So she's going to be able to provide us with some very great information that you can put into use in your practices. So at this point, I'm going to go ahead and turn it over to Dr. Donna Sheperis.
Thanks, Andrea. It's so good to see y'all. I appreciate your flexibility. Last week we were scheduled to do this training and I came down with my first ever case of laryngitis, which was quite a thing to deal with. And anyway, I could not have talked for an hour or engaged in anything for an hour last week. So I appreciate y'all being able to make it happen this week. A little bit about me. I am a licensed professional counselor and supervisor in the state of Texas, as well as Arizona, with my license pending for the state of California. Now, why is that? I am both a professor and a therapist, and I have lived in Arizona and Texas, hence the licenses there. But the university that I work for is in Northern California. I run an e-clinic out of that university, Palo Alto University, and I would like to be able to supervise my students who are working in that e-clinic. So hence the California license. I have been a licensed mental health provider since 1992, which however many of the years that is, it's a lot. I did the bulk of my training in Mississippi, where I grew up, and was an agency adult services director for 10 years in the Mississippi Delta. That was some of my first experiences with what we'll be talking about today. I've been teaching and training counselors since 2005. And I currently live in San Antonio, Texas, and am a remote faculty member for Palo Alto University, where we have a master's in clinical mental health and marriage, couple, family counseling. I am a member of the American Counseling Association, an approved clinical supervisor, a board certified telemental health provider, and a member of the ACA Ethics Appeals Committee, and have been chair of the ACA Ethics Committee. So I've been doing the work for a good while, but also engaged at the professional level for a good while. When I was approached about doing this, the reality was there was a need to talk about postvention in suicide, and there aren't a lot of people with knowledge or experience. So let me tell you a little bit about how I operate in these presentations and hopefully get your support to do so. I don't think anybody wants to hear me talk for an hour. So what I would ask is, as things come up for you, if you relate to some of the content, if you have something that would be beneficial to the group, come off mute, say something in the chat. Let's make this as interactive as possible. And let me start that ball rolling a little bit. So let's take a look at what we're going to do today. We're going to look at postvention and its need in our own teaching, training, and learning. Take a look at the ethical considerations related to postvention, and then how can we really help develop postvention as what is called the third prong of suicide prevention in our discipline. So if you could, in the chat, type yes or no if you received training on suicide intervention, and prevention in your programs of study prior to becoming a therapist. See a lot of yeses. Let's see, we got 30 people, so Octavia did not get any training, but a lot of y'all did. Prior to, no, and not yet. Okay. So my next request then, and I'm gonna type it here so that we can keep the answers separate, is give me a yes or no if you ever were trained or learned anything about postvention. So Whitcomb may be one of the few that did. Whitcomb, where was postvention mentioned for you? And if you can come off mute, that's fine. That'd be great. Oh, okay. Oh, good for you. So what I'm seeing then in the chat is that if we were even exposed to it, it wasn't in our curricula programs. And that was true for me as well. Now, granted, y'all heard me say I've been licensed since 1992. And so my training occurred well before a lot of y'all's training. And we didn't have some of the insight and information and knowledge when I went through my training. But we did know about postvention. Some of the earliest postvention research happened in the 1960s and 1970s. We just, for whatever reason, weren't training our practitioners in postvention. So today we're going to talk about the challenge of postvention and actually what that means for us as clinicians. We're going to take a look at some guidelines for practice. Sorry, going a little bit ahead of myself. I was trying to do two things, so I need to be stopped. I was trying to admit people from the waiting room and control my screen share, and I shouldn't be doing that. We'll talk a little bit about the guidelines, for postvention, and then I'd really love for us to be able to talk about what you need and what you use in your own practice. So again, go back to your chat, please, those of you that are able, and give me an idea of, first of all, I do a lot of ethics training. You heard me mention that I'm on the ethics appeals committee for ACA. I have an ethics textbook. I do a lot of teaching and training in ethics. I know why people come to ethics workshops. They don't come for the content, they come for the CEU. So I understand that a lot of you may be here to get that very precious 1 hour CEU, but I also think you're here for a reason of something that you would like to get. So what would you like to get out of this? What were you hoping to learn when you saw what the topic was? Give me some ideas in the chat or come off mute. Absolutely, Lauren. Best practices. Excellent. I mean, Elsa, you're really right there in the front lines for helping practitioners be ready for managing and dealing with suicide by teaching them in their master's programs. Yes, Whitcomb, and that is definitely my hope as well. So, you know, we're probably very familiar as a group with the concept of prevention and intervention. It is a generally recognized approach that as therapists, we would like to prevent suicide. We would like to prevent suicide in terms of someone feeling like they have no other option for living. I'm not going to get into um, right to die, which is a little different. And if you take a look at the ACA Code of Ethics, there are some ethical codes that empower in clients and their therapists to work on right to die issues and allow clients to hasten their own death when they are terminally ill. When we talk about this prevention cycle, we're typically talking about that person who has lost the ability to cope with life, that their depression, their anxiety, their trauma is so strong that they're not able to see a way out. And thus, we are trained to help educate people on mental health and try to break down stigma and barriers to access. Then, hopefully, in our training programs, we also get some information on intervention. Maybe somewhere between prevention and intervention, we learn some suicide assessments. Some of you may be using something like the SAD person's mnemonic to help assess for suicide, or you may use the Columbia Suicide Screening Scale. What we know about prevention and intervention is there's no test or perfect way to tell us when someone is going to take their own life. We don't know what is going to tip the scales for each and every person, which is why the reliability on some of those scales is not that high. It's so incredibly personal. Next question to all of you. I'm going to type it in the chat again so we can keep our answers separate. How many of you have had the experience of someone who has been actively suicidal? I'll ask that first. Client, family member, friend? All right, so universally, we have the experience of knowing someone who is considering suicide as their only option. Within our training programs, when we look at training programs across the board, we get less than 4 hours of training on this. But look at the chat, y'all. Every one of us has dealt with suicide at some level, but it is a very small part of our professional training opportunities. There is nothing that my students are more afraid of than losing a client to suicide. And we know that even as professionals, that fear is incredibly stressful and incredibly burdensome for us as mental health professionals. Now, we see an upward trend in these lawsuits against mental health clinicians. The fear that we have as professionals is not always about being sued, though. We also care deeply about the people that we work with, and we want to help them find solutions that are not just ending their lives. But we also are aware that this is something that could result in a malpractice lawsuit. And half of the families who lose someone to suicide consider engaging in some type of legal action. So if your heart rate is up right now, hearing that, that's okay. Let me take it down a notch. When we look at actual ethics board complaints and actual lawsuits around this topic, they are incredibly small, incredibly small. Using just the American Counseling Association as one example, the American Counseling Association can get up to 2,000 or more inquiries about whether or not something is ethical, and maybe only have 1 or 2 formal cases brought to the association. So the ratio of wondering if there's malpractice versus actually taking on a malpractice suit is that a big ratio or a small ratio? It's a very small percentage of the people who consider it, very small, but not zero. So we do have some professional fear around, what does this mean? Along with the fact that we are incredibly empathic, compassionate people. We wouldn't do this work if we weren't. So we worry about our clients, and we want them to find solutions that don't include suicide. And again, I am talking about not right to die or the ethics of hastening death. I'm talking about the person who chooses suicide because there's no other option for them. The person who dies by suicide is only the tip of the iceberg in terms of impact. We see with each person who dies by suicide, the average is 115 people are impacted by that suicide. That's family, co-workers, first responders, therapists, funeral home directors and staff, hospital staff. 115 people for every suicide death. And of those 115, about 20% report that the death by suicide, the impact to them personally was devastating. That is the word, devastating. So while it is horrible for that person who feels they have no other option other than to end their own life, it is also incredibly damaging to the people around them. And we know that suicide is a huge risk factor for what makes the difference between general grief and bereavement and complicated bereavement, which takes usually a therapeutic intervention. So next question, and this is a tough one, and please only share if you're comfortable. Has anyone ever lost a client to suicide? A few have. And former clients, I think that needs to be included, Alicia, because a lot of times when someone dies by suicide, they have self-terminated their work in therapy. I tell my students that if clients don't tell them that they are suicidal in general, that my student is probably doing something wrong, because humans become suicidal. They think about suicide. They think about death as an option. They have suicide attempts. So we as professionals get not comfortable, but we are accepting of the fact that our patients are going to likely need to talk about suicide, and that we might need to do an intervention. But not all of us experience a death by suicide. Probably, so some of the stats are 71% of mental health counselors have at least one client attempt suicide, and 1 in 5 of us have lost a client to suicide. 20% of us are going to lose a client to suicide, and we get 4 hours on average of training in our degree programs. That's kind of staggering, isn't it? It really sets us up for failure, especially around not only what to do in terms of prevention and intervention, but what happens afterwards. So why do I care about this topic? my friend who can't be with me today, who actually helped develop this presentation, is a suicidologist by trade. She works for Air University, the Air Force University in Alabama. She gets to train all branches of our armed forces on suicide and prevention and postvention. We know that suicide rates are incredibly high in military communities. And she knew that I had an interest in this because of an experience that I had. And that's how we started working together on this. When I was an internship student, way back, as the kids say, in the 1900s. That's so hard for me to say, but all right, way back in the 1900s, when I was doing my internship with a regional agency, mental health agency in the Mississippi Delta, we served, and those agencies that are endorsed by the State Department of Mental Health in Mississippi largely serve people who are medically underserved, mental health underserved, impoverished, economically disadvantaged, etc. And at the time in the state of Mississippi, LPCs could not be reimbursed by Medicaid. So most Medicaid recipients came to community agency mental health centers to receive services. But we also saw clients that had no ability, no insurance and no ability to pay, and they paid a flat rate of $2. I can't tell you how many times I was handed 8 quarters for a mental health counseling session. And because I was a student in training, those were the clients that they gave me, the clients that they could not bill insurance for of any type, that they couldn't be reimbursed for. It was a terrible model because we ended up taking people who were the most disadvantaged and putting them with the students that were just learning. I was green as grass. I had had one previous clinical placement, and that was in the Mississippi State Penitentiary at Parchman. If you've ever seen The Chamber or read any John Grisham books, you'd know a little bit about that penitentiary. It's pretty hardcore. It was a great, great experience, but we didn't deal with suicide. I didn't during my time there. I dealt with a lot of mental illness, but not a lot of suicide, primarily because their means for suicide were removed from them by and large. But I did learn that if someone wants to kill themselves, I can't stop them. And my clinical director gave me a lot of good insight into working with suicide. Well, I'm at my next internship site. I'm getting all types of clients, and I'm staffed a young adult male who is dealing with alcohol addiction and a lot of depression. When I see him, he has stopped drinking and is working on his depression, but that doesn't last very long. As I mentioned, a lot of times people who are suicidal will avoid therapy. They will self-terminate from therapy. And that's exactly what happened. I saw him for a few sessions. He stopped showing for sessions, and I hadn't seen him in almost a month. I went home one night and I saw a report on the news that told me he had died. And this is what I found out. He had been hospitalized. He had both pancreatitis and he took antabuse. So if you're familiar, antabuse, if you drink alcohol, it makes you violently ill. Well, pancreatitis makes you violently ill as well if you drink alcohol on top of it. So of course, as you might imagine, he drank a lot of alcohol. He went on a bender, was drunk for a number of days, in incredible pain, bleeding, ended up in the emergency room and ended up in the hospital. While there, he checked himself out AMA. He left the hospital against medical advice. And it's at that point that he died by suicide. The reason that I know he died by suicide, because it was a car accident, is that he got into his car and he headed down a stretch of highway that is very, very long and very flat. The Mississippi Delta was formerly the bottom of the Mississippi River, so it's a very flat landscape. We grow a lot of ag products, soybeans, cotton, rice. You can see for miles in the Mississippi Delta. There's no impediment to your vision. There are no hills. There are hardly any curves on the road. And he was on this stretch of highway in broad daylight, 2-lane road, and he headfirst ran into a tractor trailer rig. The person driving the tractor trailer rig said he just came out of nowhere. They were both driving on their opposite sides of the road towards each other, and suddenly my client was in his lane and front-ended him and died on contact. I lived about 40 minutes from my agency, and I commuted with some other agency clinicians. The next day, they had also seen it on the news, and they processed it with me all the way to the office. I was beside myself. I had no idea what to do. I couldn't believe that he had taken his life. I didn't know what my role was. I assumed it was all my fault, even though I hadn't seen him in over a month. I was devastated. I got to the office. If you've ever worked in a small town clerical staff know everything. They met me at the door, gave me hugs, asked how I was, said they were sorry, wanted to make sure that I was comforted and supported that day. They said they let my supervisor know as soon as he came in that I was in the office. I went to my office and I really just sat there by myself for a long time thinking about this client and thinking about what it was that caused him to take his life and my feelings about that, my very complicated feelings about it. When I look up, my supervisor is standing in my doorway and he says to me, "So, I hear you think your client killed himself. It was an accident. Don't worry about it. Have a good day." And he went back to his office. That was the postvention that I received. Now, no one else anywhere near the situation believed it was anything but suicide. And my guess is that my supervisor not only had no training in postvention, but also was probably very uncomfortable that he had this 25-year-old crying intern who doesn't know what to do, who's green as grass and desperately needed some help. And so his effort to fix this was to tell me that it wasn't suicide. And I'm here to tell you it did not fix it. And it haunted me for a long time until I discovered really the literature around postvention, and that what I was feeling was normal and that I needed to be taken care of, not told that it wasn't suicide. So we know that people are impacted by suicide. We know that clinicians are impacted by suicide. And now we know that the survivors of suicide are likely the biggest casualty. We're not great at predicting suicide. As I mentioned, the instruments that we have can only have so much validity because every individual's decision to die by suicide is so personal that we can't just take a blood test or a litmus test and know. One of the things that scares me is this last bullet point, that 20% of folks who lose a client to suicide are student counselors like myself. People that absolutely have no idea what they're doing and who show up in your office needing your help. And that's why you need to know about postvention. Hopefully not because you lose your own client. Hopefully your supervisees don't lose clients, but hopefully you're prepared if that happens. Ethically, we need to take a look at suicide from this lens that it's not just about prevention programs, which are helpful. It's not just about intervention, which can be helpful. I have had tremendous success with suicidal clients finding a way around suicide, tremendous success. And my training was very good in that, but not in what to do afterwards. And that means we are the ones that have to look to the literature and provide those empirically based interventions in postvention, so that there's a standard for postvention as a skill set separate from prevention and intervention. I love this quote. We as clinicians know that the world is full of suffering, but we also know that the world is full of overcoming it. It's what we do for a living. And suicide is one of those areas where we help people overcome and the aftermath of suicide. So postvention in a nutshell is anything that happens following a suicide, whether it's in the community, whether it's in the family, whether it's in a mental health agency, when a client dies by suicide, whether it's in a school district. The goals are to promote healing, and we want to reduce the risk of what's called contagion, which I'm sure some of y'all are familiar with, right? That there is a real tendency for suicide to become contagious. And we see, particularly in school systems. I remember when I was in college, there was a rash of suicides in a school district in Mississippi. One person died by suicide, and then they had 12 suicides in that district that year. We saw similar contagion in the area where I work in Silicon Valley, with a high school that had some really high achieving students from really high achieving families. And it was just perfection would not get you into the top 10% of your high school. It had to be perfection plus. And a student died by suicide. And again, there was this entire year, a season of suicide deaths. So reducing that risk and then trying to help connect people who would be at risk with services. We're the ones who are generally on the front line to be the guide. But what do we do for ourselves? There was no help for me, not from my supervisor. I got a lot of help from other people. So I felt like I got support. I just didn't get it from the person that I expected to get it from. So here's a fun full circle fact. Years later from this story, I was teaching a supervision workshop. The state had just set up qualified supervisor status, and you had to do 30 hours of supervision training in order to be a qualified supervisor in the eyes of the state. I'm teaching this workshop. I'm a national approved clinical supervisor. I'm approved by the state. And guess who's in my workshop? That supervisor. So I really felt like he just didn't have the training to help me. It wasn't that he didn't want to, he just didn't know. So this is basically what postvention is, helping that person. We as clinicians may not witness a suicide, discover the body, that sort of thing, but our clients will, and the families of our clients. But survivors experience all of these things. Did y'all know that there are entire businesses built around doing the forensic cleaning necessary post-suicide? That companies will come in and very respectfully clean an area where a suicide has occurred, take care of the body, take care of any of the kind of grisly aftermath that a traditional cleaning company couldn't do. And they treat it differently from a crime scene, even though the way our laws work, it is a crime scene. Sometimes survivors aren't allowed to even participate in open grieving because they're blamed by family. Well, if it wasn't for his relationship with you, he would not have needed to take his own life. That might be your client, the person who's being denied grieving. You may be helping that person. Now, here's something we do know about postvention. I would just love to sit down with you and say, when it's time for postvention, here are the steps and exactly what you need to do. We do have some pretty decent programs for postvention and we have some good ideas. But when I look at the literature, and specifically I looked at meta-analysis of postvention studies, which is where someone has gone and gathered all the postvention research and then done research on the research to try to come up with what works. There's little evidence of a singular effective model of postvention. So this is our sign to be flexible. Just as every individual's need to die by suicide is different, so is the experience of the survivor. And so you're going to have to be flexible in what you provide to colleagues, what you provide to agency staff, what you provide to client families, what you provide to clients, etc. So be flexible, but there are some things in postvention that we know are effective. A high level of support by peers, and having grieving as the focus of the support. So let's go back to my experience. My supervisor tried to support me by saying it didn't happen. And what I needed was support around grieving what did happen. So survivors of suicide, they go through a normal grieving process like we all do during grief and loss. The good old stages of grief, the denial, anger, bargaining, depression, acceptance. But they experience a lot of other emotions. And if you're a therapist dealing with your own coping as a survivor of suicide loss, you are very likely to experience guilt. And I certainly have that. You are possibly going to experience accusation from family members, even from other people in your agency, that you didn't do enough or could have done more or you should have known. And you as a therapist may not receive the adequate support necessary. Plus, you're trying to provide support to whomever else might need it if you were engaged with the family at all. So what we know is, again, survivors make up the largest mental health casualty. So I know y'all had a training last month on suicide prevention and intervention. And I don't ever want to take away from the work that you need to do with people who are considering death by suicide. But survivors need help too. Edwin Schneidman is the founding father of the American Association of Suicidology and did the largest initial research around postvention and really understood the need to look beyond keeping people from killing themselves, because the reality is you can't control them. I hear stories of inmates that are able to kill themselves by chewing and swallowing and choking on their own tongue. I can't prevent someone who wants to die from killing themselves, but I can be there to help people after the fact. When you experience a client death by suicide, you may feel like you can't talk about it honestly. You may find yourself saying, oh, I'm fine. It's really, I'm not worried about me so much. I'm worried about the family, or if it's an attempt, I'm worried about the client. And we will deny our own experience, which I think is incredibly oxymoronic given what we do for a living, but physician heal thyself, right? These are some quotes from therapists who experienced client death by suicide. I was unprepared for how shattered I felt, professionally and personally. At first, I felt like I was going crazy. Why couldn't I put it aside? Why couldn't I hold it together? Why couldn't I say that's just work? I'm a trained professional. I should be able to handle this. And yet we couldn't. And we shouldn't be, because none of us is trained to handle this. Frankly, if you could walk away from a client death by suicide with no impact, I would have to say you're probably not in the right profession. We came here because we care, and that care is definitely exacerbated by grief over the loss of a client. When we lose a client to suicide, we can get as strong a grief reaction as if we had lost a family member. And we shouldn't ignore that. We need that support. We need to process the event. We need to learn as much as we can about suicide, and frankly, learn as much as we can about our lack of ability to keep people from dying by suicide. We just aren't that all powerful. We like to think we are, but we're just not. There's stigma. Your colleagues will be like, oh my gosh, I'm so glad that wasn't my client. Or even, for me, I was sure everybody was saying, well, she's a student, so she probably caused this. No one's really said that to me, but I felt it. I felt like that's what they were saying. So remember how I was saying, like, there's no standardized manual for postvention. Well, let me take that back. We have some postvention manuals. The Armed Forces has some great postvention guidelines. SAMHSA has postvention guidelines. The American Association for Suicidologists have postvention guidelines. These are all elements of those, common elements, but just remember that there's no perfect postvention that is guaranteed to work. So first step, being empathic to the survivors. You would think that that would be second nature, but again, remember my experience. This man was a great therapist, but he could not be empathic to me. Do what you can to be there and help. Some of y'all mentioned school systems in the chat. If you are working in a school district or in a school, being able to let students know that you're there, it's safe, it's non-judgmental. One of the truths about death by suicide is you don't know how it's going to impact other people. So you may have a student in your office who is unglued, completely unglued, and you're thinking, wait, this student is in 8th grade. The student who died by suicide was in 11th grade. They didn't know each other. They had nothing in common. I don't know why this is affecting this student so strongly. That student may have had trauma in the past that's being triggered. So you never know. Oh my gosh, Kimberly, a professor in your college committing suicide. I'm so sorry. Dying by suicide. I absolutely don't mean to say commit suicide. That is old language that I was trained in, and I recognize that that is not appropriate language, so I apologize. The impact that the loss of that professor would have on students that's horrific. Being there and talking about the person who died by suicide, not saying he died or they died by suicide, but actually naming that professor, giving them a name, getting out of the moral debate about right and wrong, staying out of the religious debate. Pay attention to those folks that were right there, not just the ones maybe who worked with that person or who had a class with that person, but maybe came upon it or were in the area when someone died by suicide. And then check your own reactions to suicide. You likely have a moral stance related to suicide. Some of you probably firmly believe that if a person dies by suicide, they will not be entered into the kingdom of heaven. They will not have a sufficient afterlife. They will be stuck in purgatory. They will be in some form of karmic redo of life based on your beliefs. And that's okay. But you don't know what the belief of the person you're working with is. So be wary of your own reactions getting involved in that. Oh my gosh, Elsa, personal counselor die by suicide. How impactful must that be on a client base who look to this person to have it together? And we talk about this all the time as professionals, that our clients somehow think we're magical and we have all the answers and we know better, right? We know we are human, but our clients don't. And yes, long-term goals for those groups. How can you deal with the anger? There's a lot of anger around suicide, a lot of, how could you do this to me? How could you leave me? It necessitates forgiveness and the other people that you might be angry at. Do what you can as a postvention interventionist, if that's your role, to increase the grieving process community. We do know that people who are connected with other folks who are grieving fare better following a suicide. Do your own self-care, do your own grieving, connect with those of us who've also lost clients, do your own work around competency and feeling like you're good enough to be in this profession. Francis, I'm reading your comment. Gosh, horrendous. You had no way of knowing. You have no way of stopping. But somehow we have a little bit of belief that we really are superhuman and that we can stop all these things, and we just don't have that power. So in our final few minutes, let's take a few minutes to talk about, based on what I've shared with you, what did you know? What's new information? And how do you see yourself using this? Facilitators, Lauren, I don't know if Andrew's back. Is it okay if I come off screen share for a minute?
Absolutely.
Thank you. Great. So how do y'all see yourselves, and then I'll share some resources at the end, using any of this information? Or is any of it new, or is this all like, yep, knew that, I'm good?
So I'll share. Can you hear me?
I
Yes.
can.
Good, thanks. So I supervise a number of people as well as teach graduate students. And I think I needed to make sure that, and in this time of COVID, one of my supervisees has had a huge number of adolescents with suicide ideation. And so, and just, wanted to, and thank the Lord she hadn't had anybody complete or, but just wanted to be ready to remember everything and recheck what I knew and what I missed and what I didn't ever know. And so really appreciated just going back over that and giving attention to that post, suicide, the whole concept of what happens afterwards. So really appreciate that.
I don't know if this is your experience at your university, Elsa, but I find that my experience and the KCREP standards really place an emphasis on intervention and assessment and doing risk assessment, which is wonderful. And we all need to know how to do a quality risk assessment. But then what? We just don't really talk enough about what happens after. Elena, I was at my vet's the other day, and I had it's a big practice, a new vet had moved to the area, and he said, so tell me what you do. And I told him what I did. And he said, oh, do you know that veterinarians are, one of our leading causes of death is suicide. And we're 4th in the professions that have the most suicides, veterinarians. And it has gotten much worse during COVID. I had no idea. I knew medical professionals. I knew even therapists. I've heard religious communities. I don't know the why behind that, Elsa. But he threw it out, and I'm a bit of a nerd like this. I fact checked him when I got home. Yeah, number 4 on that list of, it's just, yeah, the top 10 jobs with the highest suicide rates: medical doctors, dentists. My dentist had also mentioned this at one point: police officers, veterinarians, financial services, real estate agents, electricians, lawyers, farmers, and pharmacists. So people that maybe we would be thinking, well, they're professionals and they don't really, deal with high risk people all the time, like real estate agents, and they're not first responders. Electricians aren't first responders, and yet there they are with some of the highest professional suicide rates. So being aware of everyone, and I really firmly believe that every adult at some point has considered, what would life be like if I just didn't live anymore? At least considered it. And I'm very open to talking about it in therapy. I think it's a great opportunity to talk about coping and healing and trauma. But we don't always think about what happens to the person who's impacted significantly, devastatingly, to use the words of that one study. That's really interesting information about vets. You just think about the impact of a pastor dying by suicide and the message that might send to a community, very much like when a teacher dies by suicide. We revere people and we expect them to be so perfect. And we are all people. We are not perfect. I'm going to share one last bit, and sorry, it's not on. This will be shared with you, Lauren. I think it's going to send this all out, but these are all clickable links to great Postvention resources, broken down by type of, by age, by type of client demographic, even for people who are running religious services, memorial services, as well as people who work in funeral homes. I mean, we absolutely have to take care of the stress and distress that is part of suicide postvention. And so I just encourage you all to think about suicide postvention as another area of what could we do to shore that up where I work or for myself. And also, of course, don't ever stop learning about suicide itself and prevention and intervention, because we want to be as helpful as possible to our clients. But when someone does die by suicide, what do we need to do? What is our role? And when it is someone who impacts us, let's take care of ourselves too, because frankly, sometimes, y'all, we're just the worst at taking care of ourselves. We're really good at taking care of other people, and then we just don't ever feel like we have time to do that for ourselves, or maybe don't even need it. So I appreciate Elena bringing that up. Yeah, so any final thoughts, questions, reflections of feeling, concerns? I feel my voice starting to give out a little bit. So obviously this was the right timing, Lauren. Our jobs are hard, Alicia. They are hard, but they are beautiful. And we don't practice without risk, but the likelihood that we will be sued is far less than the likelihood that we will suffer the loss of a client. So let's put our focus there, which is less fear and more care. Now, Lauren, I believe you and Andrea wanted to kind of wrap things up and talk about next steps, and how does everybody get credit for being your beautiful selves in this hour with me?
Okay, let's see here. We have, or I have just posted the survey link for CEU. If you would like CEUs and you have been here the entire time, all you have to do is fill out the link that was just posted in the chat. I'll go ahead and do it again just to make sure. And what we will do is tomorrow I will also be, or either this afternoon or first thing tomorrow morning, I'm going to be sending out a reminder with that survey link. As soon as we get the evaluations, we will then send out the CEU certificates and make sure that everybody gets all of the wonderful resources that were shared. We're also going to be sharing this presentation online, as well as sending out the PowerPoint presentation. And thank you so much for this wonderful presentation, Dr. Sheperis. It has been fantastic and just a wealth of information. And we so appreciate your time and ability to come and share this information with us.
Thank y'all for having me. You are holding the Houston area upright, and that's a wonderful place to be. And I'm so glad y'all have this network where you can find like-minded people to communicate with and about these topics. Lauren and Andrea, I will resend the PowerPoint, making sure all the links are working so that you have that to share with others. My email is also in the PowerPoint, and my cell phone number. Please, any of you, reach out if you want to consult about Postvention, a client who you worry is at risk, or just anything. I'm not hard to find. Been happy to talk to fellow counselors, therapists, and others in the field.
All right. Well, thank you so much for sharing this information and sharing of yourself, especially during this very busy time. We appreciate you, your ability to reschedule at such short notice. And we are so glad that you were on the mend. And again, if let's see here, I'm going to put it one more time, but again, we are going to be sending it out. The Postvention Survey Monkey, we'll be sending that out as well. And that is how you will get CEUs for this hour. Again, thank you so much for joining us all. And we look forward to our next event in January.
Bye, everyone. Have a great rest of your day.
All right. Thank you all so much and have a wonderful day.